Good morning. My name is Leeann. I am the respiratory therapy supervisor, day shift supervisor actually now at Danbury Hospital and former department educator. So I am here this morning to give you an overview of some respiratory therapy items and modalities that you'll be seeing as you move into your progressive care unit. I just did a very similar in-service for the floor nursing staff at Danbury that we're moving into the progressive care unit there. So if you have any questions that we don't get to by the end of this talk, ASHOC is always here to answer questions. The respiratory staff as well, they're awesome, and you can always email me and I can come back. We can set up different in-services if different times work better. We're usually pretty flexible with stuff like that. We're going to talk today briefly about oxygen therapy and some different items that we have for that now. Non-invasive ventilation, a very brief overview of arterial blood gases, and that is something that if you would like something in more depth, we can certainly set up at a later date. Some inhaled medications that the respiratory therapy staff here administers, and some new initiatives that will be starting for the respiratory therapy department over the next few months for COPD patients. As we all know, goals for oxygen therapy are to correct existing hypoxemia, to decrease the symptoms that are associated with it so the patients are more comfortable, and hopefully decrease their work of breathing a little bit, and decrease the workload on different organ systems that hypoxemia imposes. We do want to remember, however, that oxygen is a drug, and we actually just had this in-service and meeting at Danbury a couple of days ago to remind people that it's not just oxygen, that there are risks associated with that, and I think one of the, probably one of the more important ones for you guys to keep in mind as you're moving with a patient population that may require higher FiO2s is that when high amounts of oxygen are delivered to the lung tissue over a prolonged period of time, it can actually cause damage to the lung tissue. And because of that, you get some scarring, some inflammatory mediator release, and you can actually impair gas exchange. So I think my takeaway from that is that our goal as a team should be that the patient is on the least amount of oxygen to meet their saturation goals and to meet their needs. So if we have somebody who's on 100% oxygen, our goal really should be to get them down to a safe level, which is really 50% or below as soon as possible. And when I talk about the OptiFlow device here, you'll see actually how this helps us achieve that goal. When patients have a PaO2 of greater than or equal to 60 and they're a CO2 retainer, we say we wipe out their drive to breathe. We cause respiratory depression. If you or I was on that amount of oxygen, it wouldn't really make a difference because our normal drive to breathe is CO2. So if my CO2 is going up, I'm going to start breathing faster to try and blow it off. A patient that is a chronic CO2 retainer loses that ability, and their drive becomes hypoxia. So if we take away the hypoxia, they lose their drive and they just kind of drift into an elevated CO2 state or CO2 narcosis. If you don't know if your patient is a CO2 retainer, a safe target is 88 to 92%. And that's really, a good goal. If you look in the chart and it's somebody who, hates doctors, hates coming to the emergency room, and finally their family dragged them in, you have no idea what's going on with them, they haven't had a blood gas yet. If you target 88 to 92% for a saturation, you'll be safe really regardless of the patient population. There aren't any absolute contraindications to oxygen, and as I said, you have to take care if someone is a CO2 retainer, but it is also extremely important to remember that if they are really hypoxic, you have to give them oxygen. I can't tell you how many calls we get where they'll say, you know, Mr. Smith, saturation is 70%. And we say, okay, put them on a non-rebreather and we'll be right there. Well, they're a CO2 retainer. Well, that's okay because the hypoxia can actually be more damaging in the acute phase than worrying about wiping out their drive to breathe. So if their saturation is below their target, you need to give them the amount of oxygen needed to meet their target saturation. We have a couple of items for show and tell. The first one you may already be familiar with, and that is high flow nasal cannula. So this runs from 6 to 15 liters a minute. It comes as a set, so you have to use this humidifier with this cannula. The reason that we can run more oxygen through it is actually it's a little bit wider diameter. The section of the cannula that sits under the nares is a little bit wider, so it serves as a reservoir for oxygen as the patient breathes in. The caveats for this are that you can't put connecting tubing with it because the connecting tubing is actually a different size, diameter, so you'll cause back pressure. If you were to do that, you would probably hear this device squealing like crazy. If they are titrated down to 6 liters or below, you need to switch them to a regular cannula. It's more efficient. And in theory, this device should provide the same FiO2 as a non-rebreather. So when it's running at 15 liters a minute, it should give about 85 to 90% oxygen. And that is extremely theoretical because these devices at 15 liters a minute do not meet the whole patient's whole inspiratory demand. So if you have somebody who's fairly comfortable, laying in bed, they're breathing quietly, they may get 80–85% oxygen on a higher liter flow with this. If you have someone who is extremely tachypnic for whatever reason and they are really working hard, their respiratory rate is high, they're going to entrain air from the room, and that's going to lower the fraction of inspired oxygen that they breathe in. So it is obviously a lot more comfortable. It's a lot easier for you guys if your patient that is requiring more oxygen is just on the nasal cannula, because then you don't have to worry about lifting the non-rebreather up and trying to get their pills in them and put the non-rebreather back down before they desat, or they want to brush their teeth or wash their face, and you're trying to, okay, let me put the regular nasal cannula on under the non-rebreather so I have more than 10 seconds of time to do all those tasks. So this actually is a great device. I think it's a lot more comfortable, as I said. It's not suitable for every patient. Like I said, the patient who's more tachypnic may still need a non-rebreather. But another important thing to remember is just because the patient is breathing through their mouth, it doesn't mean they're not a candidate for this device or any other nasal cannula. Sometimes I hear people say that, oh, we can't put them on a nasal cannula because they're a mouth breather. And you can, because the oxygen pools in their hypopharynx. When they take a deep breath in, they're getting the oxygen. So I don't know how big a user you are of venti masks here. We are not at Danbury, kind of for the reason that between the traditional nasal cannula and this device, we get better patient compliance, it's more comfortable, and it seems to serve the same patient population. So I guess I would say keep it in mind, and remember that the patients don't have to really keep their mouth shut for them to achieve a benefit from this. I'm assuming that when you have patients that come in like one day for procedures, and if they may end up staying, they use a different nasal cannula for conscious sedation that actually monitors end-tidal CO2. Looks almost the same, but it's not as soft. So we've had instances where, the patient comes up, they get in the bed, and then it takes a little while for somebody to say, oh wait, that's not the same cannula, so I guess I would say anytime that you have somebody to come in, whether it's, after a procedure from a nursing home, just check what they have on to start with, because for the traditional nasal cannula that we have actually is a lot softer than a lot of the ones on the market, and that can help from a skin integrity perspective. Our other option, which you will be getting, and I'm going to move this in front of the podium here, is called the OptiFlow, and it's actually a heated high-flow oxygen device. It runs from 10 to 60 liters a minute. It has an FiO2 of 21 to 100%, and it actually this is the cannula that the patient wears. So it sits pretty much like a traditional cannula. It's a little bigger. Again, these are kind of a not so great elastic strap because you do have to watch, on the top of the ears. But this device really has been a godsend for us to use because it really serves that patient population that maybe isn't tolerating, or the non-rebreather or the high-flow cannula isn't quite enough, and they maybe don't tolerate BiPAP, they don't want to go on. It's really a good stopgap for those patients. The things that are important to know about this device are that it is heated, so when the therapist sets it up, we turn the heater on. So if you can imagine, you don't want 60 liters a minute of cold gas running into somebody's nose. So it is heated, but you will get some rain out. This part of the tubing is actually a breathable fabric that allows some evaporation to occur. So you shouldn't get a lot, but before you boost the patient, turn the patient, lay them down, you want to make sure that there's not a lot of water in the tubing here. The other part of this section here actually fits around the patient's neck, so it helps to support. It does have a breakaway so that it can't get stuck. And you want to always record the amount of oxygen that they're on and the liters per minute that the patient is receiving.
So are you saying 60%?
No, I'm saying 60 liters a minute.
60 liters a minute?
Yep. So,
Yeah, I was gonna say.
this is the analyzer where you will see the amount of oxygen that the patient is receiving. This flow meter will tell you how many liters a minute. So if we are meeting the patient's entire inspiratory demand, so they are on 50 liters a minute and 50%, as long as we're meeting their whole inspiratory demand, they should not need to entrain any air from the room. So it'll go up to 50, why we're not. Doesn't like me today. So you want to document both. If you have someone who is very comfortable on their 40 liters a minute and they're satting 92%, and you get them up, they're going to get up to sit in the chair, they're going to get up to use the urinal, and they desaturate and they drop into the 80s. I think everyone's first instinct, and it's certainly something to do in the short term, is to turn the amount of oxygen up. But the other thing that the therapist will need to be thinking about is, do they need more flow? Because if they had enough flow to meet their inspiratory demand on exertion, the original amount of oxygen could have been enough for them. So I think my best example of that is when we first started using these, I had a patient who was in the hospital because he had a reaction to his chemotherapy. And he had like a pneumonitis, and he was extremely short of breath, extremely hypoxic, didn't tolerate BiPAP, just was really because of his anxiety more than anything else, because he was so uncomfortable. So these were fairly new, and we put him on and we tried it. And he was on 30 liters a minute and 40% oxygen, and really satting like 92%, and everybody was, you know, happy, because we had been battling between a non-rebreather and the high flow cannula, and the non-rebreather over the high flow cannula. And he got up on the side of the bed to use the urinal, and his sat went to 70%. And everybody's like, oh, well, that didn't work either. Like, no, wait, let's wait. Let me turn the flow up so that when he needs to scoot back in bed or move up a little bit, we're meeting his whole inspiratory demand. When we did that, we were able to bring his FiO2 back down and maintain him on pretty much his original setting. So for the respiratory therapist, there's two things that they'll have to worry about titrating: the oxygen and the liters per minute. So if somebody's on 100% and they're on 40 liters per minute, the first thing that we're going to be turning down is the FiO2 to get them back in that safe range, and then we'll start titrating down the flow. But it really is a remarkable device.
So I don't understand, 40 liters a minute, I don't get that, going through your nose.
Yep.
I don't understand. You know, FiO2 I get.
Yep, so the unit is actually delivering the gas
Of
at
40 liters
at
per
40
minute.
liters.
So what does that equate
up
to?
to
Like
60
we don't,
liters a
you
minute.
know what I mean? If versus like, you know, BiPAP or CPAP or being on a vent.
Oh,
You're-
so,
So if you're on say you're on 100% on a vent, you know.
well, it's two different things on a ventilator as well. So on a ventilator, the FiO2 that you have set is completely independent of the flow. So depending on the mode of ventilation on a ventilator, the patient can determine the flow or we can set the flow.
Okay.
We may set the flow at 35 to 40 liters a minute. On BiPAP, the flow is really patient determined, but again, it's in that probably maybe 50 to 60 liter a minute range. So in some respects, it is kind of equivalent.
So this is almost essentially like.
They don't market
okay.
it as being, it's not non-invasive ventilation, and they don't market it as providing any end expiratory pressure.
But it's the same thing.
But
You're using
a
the same.
function
Okay.
of a function of the high flow is really a little bit of PEEP.
Yeah. Okay. I get it.
So that helps from a work of breathing standpoint as well. So it's a good, another good tool in the toolbox to say, all right, you hate the BiPAP. You know, you were on, you know, 10/5. Let's try you on a higher flow on the OptiFlow, because doing studies, they found really that every 10 liters of flow provides about a centimeter of water pressure. So if they're on 60 liters a minute, they're probably getting an inadvertent PEEP of about 6. You know, they can't market it that way.
So the first thing you're going to titrate is the FiO2.
Yes, to get them back in a safe
Okay.
range. If all things being equal, their FiO2 is 40 and their flow is 40 and they're looking pretty comfortable, we're going to start turning their flow down, because if they get down to a flow of, you know, 15 liters a minute, we can transition them back to this, which is a little more, which is a lot more comfortable actually, and it's a lot quieter. The other thing that you will need to know from kind of an emergency perspective is, on the side of the unit, there are 2 knobs. The top one controls the oxygen, the bottom one controls the flow. So if your patient is desaturating, you're calling the therapist, they're coming, but you're watching the sat go down, you can turn up the FiO2, you read it here, and you do have to give it a few minutes for this to equilibrate. So you'll be turning. This number will be changing, you just have to wait for it to hit its target. The other thing is, say your patient is titrating off, and they were on 20 liters a minute on this and 35%, and therapists are like, oh, let's put them back to a regular high flow cannula. We're going to leave this in the room just to make sure everything is okay. There's a knob on the back here, a little lever right here. It's blue on the top. And when you turn it, it turns the gas flow on When you turn it back, it shuts the gas flow off. So if your unit is extremely quiet, like this one is, because I'm not sure why it's not cooperating with me today, and you go to put the patient back on because they're decompensating a little bit, put the cannula back on, you don't really need to worry about the heater in that short term because you're calling respiratory at the same time. You just remember to turn this little lever on. It will go back to the last settings that the patient had. So you can't really put them on, the wrong amount because it's gonna just go back to where they were before. And then when the therapist gets there, they can reassess and kind of figure out if it's the best time to turn the heater on and make any other adjustments. We do monitor these patients every 4 hours because they are on a high flow and a lot of oxygen. And you guys probably have a lot quicker conversations with the respiratory staff here than we have at Danbury, but you're giving a report, you can't, oh, the therapist just told me what they turned them down to, I don't remember what it was. We actually document it on an assessment that shows up in the patient record in Sorian. So if you're on the patient record and you choose the respiratory drop-down, anything that we do with the patient is actually reflected in the upper portion of the screen, and you just click on the little check mark and it'll open up and tell you what we've discovered. And I can tell you that it's a lot of good information, and the therapists here are really good about writing a lot of pertinent information about their patients, either on that or on, we do have a progress that we use as well. So any of those are a really good resource for kind of figuring out what the thought process was, and they're always a very good resource for kind of just-in-time reminders for things like this. So I'm showing this to you now. It could be, 3 months before you actually use it, and you go, oh great, she showed it to me, I don't remember it. Ask the therapist, they'll be able to give you that just-in-time kind of update. Remember, you turn this knob, this is where you read the FiO2, this is where you read the liter flow. So take advantage of them as a resource because they are, they're great. The next thing that we're gonna kind of, as a little segue to, is non-invasive ventilation. How many of you are familiar with BiPAP? Okay, so BiPAP is kind of a catch-all term for non-invasive ventilation, and it's kind of my goal, I guess I would say, is to get people to start to think about it as non-invasive ventilation and not BiPAP, because again, just like I said, sometimes people get in the habit of saying it's just oxygen. I can't tell you how many times I've heard it's just BiPAP. And it really, we are ventilating, we are aiding these people's ventilation, so there's nothing just about it. It really is life support for them. Here you have 2 devices. The one, this one, BiPAP Vision, a little older device, still works very well. The other one is the V60, little more bells and whistles, different modes of ventilation on it. Both really, the BiPAP Vision has really been the workhorse of this mode of therapy for many, many years. So both really do a very good job. Why do we want to use BiPAP? We want to use it either as a continuous mode or intermittent, and we're assisting the patient's ventilation, and it really depends on the patient's clinical situation. I will say that when I speak to hospitalists or residents, or when I'm lucky enough to speak to nursing staff, I always say that part of the successful implementation and plan of BiPAP is to have a plan to stop. So you need to know what you're going to do through the whole plan of care. So If it doesn't do well, if the patient doesn't do well on it, and they're a full code and you can intubate them, and okay, so that would be the next step if we don't do well. They do well, we're able to get them off, that's great, but it's the patients who maybe are do not intubate or do not resuscitate, they go on non-invasive ventilation, they're fine on that. How are we gonna, what's our next step if they're not able to come off? So I always have that conversation at Danbury. I have it with the residents because I think sometimes they forget that there needs to be a goal. You know, not everything always works out exactly the way we intend. But we have it with the hospitalists as well to say, you know, what's our total plan of care? We're using this device to provide support for the patient either through a nasal mask, a face mask, or a total face mask. And I have some examples that I'll show you in a bit. We want to increase their oxygenation and we want to improve ventilation. As a consequence of both of those, we hope to decrease the patient's work of breathing and avoid intubation. I can tell you that over the course of my career as a respiratory therapist, it's amazing how far we've come in really not that long a time. In the 1950s, non-invasive ventilation was negative pressure. So the patients, like in the polio epidemic, would go in an iron lung. They would create a negative pressure, it would pull their diaphragm down, air would go in, and then they would exhale passively. Then after that, they discovered, oh, we're gonna intubate everybody, that'll be great, mechanical ventilation is awesome, we're gonna save everybody. And we didn't, because in the beginning, we didn't really do it that well. We didn't know about all of the, you know, risks that were associated with it. And then non-invasive ventilation probably came back, I would say starting, what do you think, like in the 1980s? The first devices were very basic. They provided pressure. They did not provide any oxygen. So kind of if you think about it, if you know people who use CPAP at home, kind of that same kind of thing. Gave them flow and pressure, didn't give them any oxygen. We used to have to bleed it in. I can remember standing in the ICU at Danbury Hospital when we got the first BiPAP vision and thinking, oh my God, I can give oxygen through this. And it was like the best thing since sliced bread. And now the options that are available on the newer units really are amazing where they've come in a really short amount of time. To be successful with non-invasive ventilation, the patient has to be breathing. They have to have spontaneous respirations. As I said, the availability of the modes differ by the machine. BiPAP or bilevel positive airway pressure is the most commonly used mode. It has a continuous flow of pressure, a continuous flow that cycles between two levels of pressure. So if you have a patient on BiPAP and the therapist says to you they're on 12/6, 6 is the pressure at expiration, so it's positive end expiratory pressure. That helps stent the airways open, it helps keep the alveoli open, and it helps improve oxygenation. The higher pressure level is really, it's the cycling between the two that aids in ventilation. So if you have a patient who is in respiratory failure and we put them on non-invasive ventilation and the respiratory therapist gets a blood gas and their oxygenation is much better, but their CO2 is still a little bit higher than we would like, what we would do for a setting change is to increase the upper pressure, because then we have a bigger pressure gradient between the two levels. That helps aid in ventilation and helps get rid of CO2. And it also, for the patient that is acutely short of breath, very tachypnic, it really will help decrease their work of breathing and rest the respiratory muscles. You may see, we're seeing an increase in the number of patients with COPD who use a very specific non-invasive ventilation device at home, and it really is to rest their respiratory muscles at night. So you might see, normally you would think of it in the acute situation, the patient with respiratory failure, whether because they're septic, they're in CHF, they have pneumonia, the patient who uses CPAP at night because of obstructive sleep apnea, so we're trying to use that lower one continual pressure to keep their airways open. But we're seeing an increase in the amount of patients who are on very specific devices at home to be able to rest their respiratory muscles. So the COPD patient, the patient with muscle disease, all of those are being effectively managed by the devices, and that's why I kind of like people to remember that it really is non-invasive ventilation, not just the one mode of BiPAP. When you have your patient on, you're going to measure the effectiveness by looking at them. Do they look more comfortable? Are they not in as much respiratory distress? Are their blood gases better if we're doing them? And there are a lot of advantages to this mode, but I will say that, you know, it really is, the time that's spent with the patient at the initiation pays off in the end as far as effectiveness and being able to take advantage of all of the benefits of this mode. So we preserve airway defense mechanisms. Patient can still cough. We can provide early ventilatory support. So the patient who has had COPD forever and comes in with pneumonia, we're going to hold off until the last minute before we actually, if intubation is an option for them, because we don't want to put them in a situation where we may not be able to get them off the ventilator. With non-invasive ventilation, it's much easier to step in earlier, because what are we doing? We're putting the mask on, we're taking the mask off, so it's not as invasive. We can provide it intermittently, so the patient can go on continually at the beginning. As they're getting better, we can take them off for periods of time. They can come off, get oral care, eat. They can just go on at night. They can talk to you, which is nice, because, trying to read lips of somebody who's intubated is, even after all these years, not my best skill set. And at least with the BiPAP, although they may be talking to you while it's on, you're going, hang on a minute, let me just take it off. At least still, it gives them, the feeling that they can actually get their needs known. Ease of application and removal. So, in theory, it's easy to put on and off. I'm going to show you, you may be familiar with some of them. I would say, once it's on, it's very easy to get it on and off. Getting the right size and the right fit is, again, something that the time spent at the beginning by the respiratory therapist to get the right size mask and get it on appropriately makes it easier for you to take it on and off when you need to interact with the patient. Reduced sedation requirements. Obviously, if somebody's intubated and on a ventilator, we want to keep them sedated and comfortable. With non-invasive ventilation, we don't have to do that to the same extent. We don't want to do that. And again, that, I usually just phrase it and say the hand-holding at the beginning. So explaining to the patient why they need it, what we're going to do, what it feels like, really goes a long way in decreasing their anxiety and making it more effective. By not putting them on a ventilator, we're avoiding the complications that come along with intubation. And if the patient ends up needing continued support, having it through a non-invasive mode then does not preclude discharge, because as I said, there's a lot of patients in the community that are actually using these devices either intermittently or at night at home. The disadvantage, the masks are uncomfortable. We have a variety of sizes, but as with many oxygen delivery devices, no matter what company, no matter what brand, sometimes it is a situation of, I sometimes say one size fits nobody. Like, there's always going to be the patient where it's a little too big or a little too small. They have sizing guides that we use to make sure that we're getting the most appropriate size for the patient, but it's still not the most comfortable thing in the world. And they can be claustrophobic, so just think about it. If you were having a hard time breathing and you're anxious because you can't breathe, and I come at you with a mask and I say, we're gonna put this mask on, it's gonna be tight, but it'll be fine, and I just strap it on, and now the mask is tight, you can't wear your glasses anymore, all this flow is coming at you. If you weren't claustrophobic before, you're probably going to be once I'm done with you, if that's the little bit of information that I've provided. It is time consuming for the staff. It's time consuming for the respiratory staff, it's even more time consuming for the nursing staff. Because the patients are awake, they need more interaction, they need more explanation. It's really not a set it and forget it mode or machine. We want to, it is a lot more work. The airway isn't protected, so that's why I said they need to have spontaneous respirations, they need to be able to cough, they need to be able to clear their own secretions. And if the patient requires suctioning, it's not like they're intubated where we have a direct route. We would have to take them off and nasally suction them. To be successful, as I said, you have to have a cooperative patient that can maintain their airway, clear their secretions, coordinate their breathing with the units. So the benefit of the V60 is there are a few more choices for modes of ventilation. So we can fine-tune the choices a little more for the patient to make it a little more comfortable. The patients need to be able to breathe without support for a couple of minutes so that you can, give them their meds, do oral care, assess their skin integrity. They need to be hemodynamically stable. They need to have a pH of, a lot of sources say 7.1, our policy actually says 7.2, and a CO2 less than 92 is ideal, not the only situations where we do it. And ideally, the patient should show some improvement within the first couple of hours. They should look more comfortable, their saturation should be better, and their blood gases should have shown some improvement. So, why is the interface the problem? These are the masks that we have available right now, and I'll pass them around in a minute. If they're not super comfortable, it's harder for the patient to be compliant. So we do have two that we can switch back and forth. If it's not the right fit, it's a little too big, it's a little too small, you're going to have leaks if you blow air into the patient's eyes, right up into their mouth, all of those things, a little more leak, less compliance. We can have skin breakdown. So skin breakdown is something that we're all concerned about and we need to worry about. If the patient's on continually, it's a good idea to probably be switching back and forth between the devices if they're on for more than maybe a day, because they're already probably in a compromised state, so their skin integrity isn't great, they're going to have skin breakdown. Obviously, if we have this mask on, the patient really can't tolerate being off for that long, it's hard to understand them. Some of the headgear can be a little complex, so there's a lot of pieces, there's a lot of Velcro, there's a lot of clips. Once the therapist sizes the patient and has the mask on, all you should really have to do is unsnap the bottom. Once these are unsnapped, they flip up and they're pretty easy to get to the patient. That being said, when I gave this similar in-service to the progressive care unit nurses at Danbury, a couple of them were fairly new, and I saw one of them last week and she's like, you know how you told us that we didn't really have to touch the masks? I said, yeah. And she's like, well, I didn't really understand why, because what's the big deal? Well, then her patient ripped everything apart. She went in, the mask was unclipped, the Velcro was gone, and she said, and I tried to put it back together, and I thought I got it back together, and I put the patient back on, and I called the therapist, and you know, this strap was down here, this one was over here. We actually had to take it all apart, lay it out, and put it back together. So the ideal is that you should only have to unclip it and flip it up. And studies have shown that clinicians, between nursing, respiratory, when the hospitalist comes in to talk to the patient, the headgear is removed 18 to 20 times a day. So that's a lot for something that counts on a good fit and the right, the straps being on correctly to actually provide ventilation to a patient. So that's a lot of people's hands in the pie affecting how it works. This one, as I said, is one of the ones, probably the one you'll see most often. This is called a full face mask. It fits from the bridge of the nose to the chin. When you're gonna need to take the patient off, you unclip the bottom, and you can just flip this up so that you can give them their pills, do oral care, look at their skin integrity. This one is called a total face mask, and it actually fits, we call it a fireman mask. It fits over the patient's eyes, covers their whole face. And you look at it and you think, how in the world is that comfortable? Who's gonna tolerate that it's covering their whole face? And we've actually found that for some patients, it's actually more comfortable. Obviously, neither one allows you to wear glasses, so if you're a glasses wearer like I am, you're kind of out of luck. Everything is gonna be a little blurry. But this one also, because of the position of this piece here and the fact that it fits over, it actually disrupts patients' line of sight. If they're moving and the mask moves a little bit, they can get, you know, more air blowing in their right eye than their left eye, and it's a little bit uncomfortable. This one, because the flow is a little more dispersed over their whole face, they don't get that sensation of like a shot of air blowing into their eyes. They can actually have a good line of sight, so it is a little more comfortable for some patients. And as I said, the patients who you notice like the bridge of their nose is getting red or they're having a little redness on their cheeks, it's a good idea to go back and forth between both. Both of them, as I said, require some hand holding. I think this one requires a little more explanation because it's a little scarier looking when you come and say, I'm going to cover your whole face with this mask. But explaining that, you know, you might be able to see a little better, and you may not feel the air blowing quite as much can go a long way. And we've had really good luck with both of them. And I'm going to just pass them around so that you can play with them. You already know all this. To avoid skin breakdown, we do, even though these are a pretty high quality, actually they're a very high quality mask considering other ones we've looked at, you want to make sure that because skin breakdown can occur in just a few hours, that we do put Methylex on the bridge of the nose. Almost up to a quarter of the patients that go on non-invasive ventilation end up with some kind of skin breakdown. And as we all know, you know, that's something that everyone is extremely concerned about. It's non-reimbursable, and I've seen some that are really quite impressive, and they can really happen very quickly. So when the respiratory therapist documents on these patients, we actually also assess skin integrity. They'll be talking to you, especially if it's something other than just normal skin, because we actually use the same classifications that you use, but we need your input into determining what exactly, this is the list we have of descriptors, which fits the best. If it's anything on our documentation other than normal skin integrity, no issue, if we pick anything other than that, our flow sheet actually sends an alert to the wound care nurse so that she'll come and look at the patient. The other thing that we have to document is if we pick anything other than normal skin integrity, we have to document that if we spoke to the nurse about it. So all of us will be looking at it and communicating about it to hopefully, really catch it before it gets worse. I know that you guys look at skin integrity and the risk factors for that on admission. And from that perspective, you're a good resource for the therapist to say, you know what, I did my admission assessment. This patient's, nutritional status has been horrific for a few weeks at home already. What do you think about just having the 2 masks available right away, so that instead of just keeping one on, we can go back and forth? So again, as a team, it really helps in catching those things that we may not be thinking about. We may not be thinking about, gee, how is their nutrition then? Are they really gonna, how does the rest of their skin look? So it really, from that perspective, is a big help to us if you can just, remind us to say, you know what, I know that you guys have more than 1 mask available, maybe can we start it sooner rather than later? The other thing that I want to really stress is that these do not have to be on really tight. So again, a million years ago, when I started as a respiratory therapist, we used the masks similar to what come on the ambu bag. And we had thick plastic headgear straps that would fit around, am I correct?
Yep.
And so the masks had little hooks on them, and we would pull this and strap the masks on. So they were extremely tight because the machines weren't that sophisticated. So we needed that super tight fit so that there was no leak, so the patient would get the set pressure and the set amount of oxygen that we were bleeding in. Thank goodness we don't have to do that anymore. All of these masks, it's okay for there to be a leak. If you should feel a little bit up here, if you feel a little bit down here, it's okay. You don't want it so tight. If you ever look at the device and it says that the leak is 0, that's not good. Then the mask is really too tight. The devices, both the BiPAP Vision and the V60 can compensate for a leak up to a certain point. So the machines are able to kind of keep up if there's a leak, for lack of a better term. When we have a patient on the V60, actually the first steps that the respiratory therapist does is a little self-check with the device. And the masks that we use in the circuit that come on those machines are actually proprietary to that unit. So when we plug in the numbers that are associated with those masks and circuit, the machine knows how much of a leak there should be. Just kind of endemic with the mask and the circuit. And then it will be able to measure then how much of a leak there is because of the patient. So by doing that, it's able to keep up a little bit better. It's able to make it easier for the patient to trigger a breath. But as I said, they do not have to be strapped down tight, and a leak is a good thing. And I just want to see, before I move on to blood gases, because we actually had to use the V60 last night, this is what the device looks like. The bottom part of the screen here is actually the settings. So If a therapist isn't around and you want to know exactly what the patient's on, you read it at the bottom. The top portion of the screen is actually what the patient is doing. So if they're set on an inspiratory pressure of 12 and an expiratory pressure of 6, you can read out what kind of a volume they're getting with those pressures. You can read out how fast they're breathing. The therapist will look at how much of a leak there is. The therapist can look at whether how much the patient is assisting. And as I said, the items down here, there's little choices. We do have different modes of ventilation that we can use with this. We do have the ability to ramp up to the set pressure. So again, back in the day, you were on BiPAP of 14/6. I put the mask on. You were at 14 right away. Not always that comfortable. If we're putting a patient on who's really not in a super acute situation, and we know that that compliance at the beginning may be a little bit of a struggle for them, we actually have the ability now to ramp up to the set pressure, so the first few breaths will not be at that high pressure. It gives them kind of a chance to work with the machine, get used to it before it gets up to the high pressure. If we have somebody who is extremely short of breath, you know, you've got the COPD that came in and they're like, I can't breathe, I can't breathe, I can't breathe. We actually can do the opposite and make it get to that high pressure extremely quickly in the inspiratory portion of the cycle. So normally it might take a little bit of time. It's in milliseconds really to reach that set pressure. But we actually have the ability to make it reach the set higher pressure a little bit quicker for those patients who are extremely short of breath, and it kind of will give them the feeling that, oh, I'm getting it, because they can really feel it blasting at them. And so those things are really patient-specific that the therapist is able to fine-tune on these devices, which is very nice. The other thing to know, actually, before I move away, is there's an alarm silence button. And I don't know about you, but when it comes to troubleshooting, I don't troubleshoot very well when something is beeping in my ear. So unless the reason for the alarm is extremely obvious, like the patient has the circuit in one hand and the mask in the other, I find it helpful to hit the alarm silence button. And then the machine actually will tell you what the alarm is. And it will say high pressure alarm, it will say low pressure, it will say low volume, so that can kind of aid in troubleshooting. You're going to get a much quicker response from the respiratory staff here than the nurses do from the respiratory staff at Danbury, just because of our size and the area that we're covering. But still, if you call the therapist and say, Mr. Smith's BiPAP is beeping, they may say, what's going on, what's it saying, maybe they're in the emergency or doing something. And that's not, sometimes you think, why are they asking so many questions, why don't they just come? Part of it is they're on their way, but knowing what the alarm is can kind of help them, as they're coming, troubleshoot in their head what could be wrong, what could be going on. Did the pressure line come off? Did the filter crack? Does the mask need to be readjusted? So the more information that you can give to the therapist is really very helpful. If you're in a room and with one of your other patients and you hear the unit alarming and your other patient's on isolation, and by the time you get ungowned and get out of the room, it's not alarming anymore, like, okay, great, now I wonder what was going on. If you go in and look at the unit, it will actually keep track and it will tell you what the alarm condition is after it's self-corrected. So say the patient was coughing and that created a high pressure alarm, the machine shuts the alarm off when it's not occurring anymore, but you'll still be able to get a digital readout of what went on. So it's kind of a good tool to say, oh, what's going on when I wasn't in the room? Oh, there was a low volume alarm. Let me look, oh, the mask looks okay. Were you moving around a little bit? Oh yeah, I boosted myself up in bed a little, and the mask could have just shifted a little bit. So all of those little things are nice, and again, when I come to do this talk again next week, I'm actually going to bring a unit, so that you can see it. The people that come next week can see it, but the respiratory staff here will be able to go over it with you. Again, this is an overview, and the just-in-time training is really very important. So when you have your first patient on BiPAP, you should ask the therapist to go over it with you. Where do I find the settings? Where do I find the alarm silence? How do I know how fast the patient is breathing? And, you know, they should review all that with you before they, you know, as they're putting the patient on and before they leave the room, just so that you have an increased comfort level with it. Because, like I said, both devices show it in different places, and one is a little bit more advanced than the other, I guess I would say. Before we move to blood gases, any questions on BiPAP? Okay. And again, this is a very, oh, go ahead.
When we use this total face mask,
Yep.
the oxygen is going to the eyes. Is that giving any complication for the eyes?
No. No, it could be a little drying, but there's nothing to the eye tissue itself. When you hear about oxygen injury to eyes, it's usually when the blood vessels behind the eye are developing. So before birth, or for preterm babies after birth, because they're still developing. And in those babies, high levels of oxygen actually interrupt how their blood vessels are developing in their eyes, and that's why, you know, before we knew a lot of oxygen was bad, like around the time I was born, a lot of preterm infants actually were blind because they put them in an isolette, they gave them a lot of oxygen. Oh great, they're pink, their oxygen, you know, level is perfect, but we were destroying their blood vessels that were still developing. So that's usually where you see that. For this, it would probably more be just a comfort of maybe a little bit dry.
Thank you.
Blood gases tell us about the patient's oxygenation, and they tell us about their acid-base balance. So pH is going to tell us about acid-base balance. The normal is 735 to 745. PCO2, the normal is 35 to 45. Bicarb, normal is 22 to 26. And I don't know about you, but I don't know, a whole lot of my patients actually fall into that normal category. So it's also important to know what's normal for the patient. So one nice thing about electronic medical record is a lot of times you do have that picture of blood gases that have been done before. For you guys, probably the most common place to see it is there's actually a spot again on the patient record that says respiratory ABGs. If it's a patient that has gone back and forth between Danbury and New Milford, you would look also under point of care results, because we do point of care blood testing at Danbury for blood gases. So you would find it in both of those places, because you want to know what's normal for the patient. We had a patient, long-term patient, who would come to the hospital when she had a headache. She had a headache because her CO2 was 130. So she would come to the emergency room and she would say, I need a blood gas, I have a headache, because she knew what was going on. And I remember they called me from the emergency room, oh my God, we need BiPAP right away. Patient's CO2 is 135. I'm like, okay, I'll be right there. What's the patient's name? Where are they? They told me the patient's name, and I'm like, what's she doing? Well, she's on the phone. Like, then it's not really staff, because if she's on the phone telling her sister what to bring her to the hospital, yes, she needs it. Yes, it's in an acute state, but it's not like it's somebody whose normal CO2 was, 48. Her normal CO2 was 80. So it's important to know what your patient's normal blood gases are. If we have someone who has respiratory acidosis, their pH is less than 735, and their CO2 is greater than 45. And we can have this because of CNS depression, impaired respiratory muscle function, either because of muscle fatigue or medication, like, you know, if somebody's just had surgery and the anesthesia hasn't quite worn off yet. Pulmonary disorders, so, you know, the patient in maybe a COPD exacerbation, and as I said, hypoventilation from other causes. What are you going to see? They could be extremely short of breath, they could be very dyspneic, shallow respirations, they could have a headache, they could be restless. Sometimes you'll see as their patient's CO2 goes up, they'll start like picking at the blankets and picking because they're starting to have some confusion. They, at the end, become more lethargic, drowsy. They could have tachycardia, and they could have some arrhythmias. What are we going to do about it? We're going to increase their ventilation. So for your patients, we're going to put them on non-invasive ventilation. We're going to make sure that they have a stable airway, and we didn't kind of miss the window where we could jump in with non-invasive ventilation. And we're going to stabilize the patient, resolve the underlying causes. So what caused them to have a respiratory acidosis? Is it a patient who is post-op and got too much sedation? Is it someone who is in a COPD or who now has pneumonia and that kind of tipped them over the edge? For some patients, well, mechanical ventilation is required for all of them. It can be provided non-invasively, or if that window has closed, then we would have to intubate the patient and provide mechanical ventilation that way. But if we can catch them before their pH gets too low, non-invasive ventilation is actually a great modality to treat this. If someone has respiratory alkalosis, their pH is greater than 745 and their CO2 is less than 35. And we can have that, there could be psychological responses. Somebody's anxious and they're hyperventilating, pain, fever, sepsis, hyperthyroid. Any of those things that are going to increase your metabolic demand can cause respiratory alkalosis. Medications, like an old school respiratory stimulant like theophylline, it increased the drive, and some central nervous system issues can do that as well. The patient's going to feel lightheaded. They may have some numbness and tingling in their extremities, hard to concentrate, blurred vision. Again, they may have some arrhythmias. They could have palpitations, be very diaphoretic. I would say you probably see that in the patient who really is like that anxiety component. They're hyperventilating so much that they are going to have, then they start, now I'm having palpitations and my vision is getting blurry, and they could have a dry mouth as well. What are we going to do for that? Slow their respiratory rate down if we can to try and avoid respiratory fatigue and monitor them. So if it's somebody who's anxious, if we can work with them to make them less anxious, breathing into paper bags still works to rebreathe CO2, and watch them closely. If a patient has metabolic acidosis, their pH is less than 735 and their bicarb is less than 22. But we could have that because they have diarrhea, they're in renal failure, they've been starving themselves, they've taken medications that can cause it, and again, obviously headache is a popular sign and symptom for a lot of these. Confusion, restlessness, lethargy, again, they can have arrhythmias, warm, flushed skin, Kussmaul's respirations, which is just, they're breathing very fast and they're breathing very deep. So their whole respiratory pattern is, and they just keep it up. So that's a very specific pattern for this issue. And they can have nausea and vomiting as well. Metabolic alkalosis, a pH of greater than 7.45, and a bicarb of greater than 26. Could be because of ingestion of antacids or excessive use of bicarbonate, use of lactate and dialysis, excessive vomiting, gastric suction, too much diuresis can cause that. And from a signs and symptoms perspective, you would see respiratory depression, again, dizziness, lethargy, disorientation, muscle weakness, some twitching, and you can see some nausea and vomiting. I think probably that was a very brief overview. If you want more information, we can certainly provide that. I think the biggest takeaways from looking at blood gases are, if you can know what's normal for the patient, that's the first place to start. Because someone, we really didn't have time today to talk about, compensated states, but someone may have a normal pH, their CO2, their baseline CO2, again, maybe in the 50s or 60s. Their bicarb may be elevated because that's where they live all the time, so it's important to know what's normal for your patient. And I think when I look at a blood gas, the last thing I look at is their oxygenation. I look at their pH first, then their PCO2, their bicarb, to see whether it's an acid state or an alkalosis, and to see what's causing it. Is it a respiratory issue or is it a metabolic issue? But those are probably the most important pieces of it. I mean, you guys are probably used to looking at blood gases already. This patient population that you're going to be seeing may have them a little bit more. Again, the therapist is a great resource to say, here's the blood gas and this is what we're going to do about it. I always, like to say that, handing, if I do a blood gas and I hand it to you, if I don't tell you what my plan is, that really, I kind of put a barrier up and there's no, communication about it. I want to say, this is the patient's, the patient was started on BiPAP of 12/6 an hour ago. I just got the blood gas, here's the result, and this is what I'm going to do. Their CO2 is still a little high, so I'm going to increase their inspiratory pressure, but their oxygenation is better, so I'm going to decrease their FiO2. So that's the optimal situation where you get that kind of back and forth communication. And please don't be afraid to ask the therapist, what are you going to do? Okay, here's the blood gas, what are you going to do about it? What kind of changes are going to be made because of this? And they really do have, pretty quick turnaround time for the results. It may take a little bit longer to show up in the EMR, but they always, because they draw them and run them, so they have, real-time results for you. So that's really a real benefit that they have that ability to be able to get that information to you right away and get it to the hospitalist and have that group discussion about what's going to happen next. I wanted to talk briefly about some medications, inhaled medications that the respiratory therapists deliver here, because it kind of is a segue into two initiatives that I'm going to be talking about. One of them that you're probably very familiar with are dry powdered inhalers. So the most common one that we see is Advair. It's administered twice a day. It is a maintenance medication, so the patient needs to take it every day. It's a combination of a long-acting beta agonist, so that's a medication that helps relax the airways, and an inhaled steroid. So the long-acting beta agonist helps to relax the airways. The inhaled steroid helps to reduce inflammation. So taken on a daily basis, it's a maintenance medication. Because of the inhaled steroid, the patient needs to rinse their mouth after they use it, because you don't want to get thrush when your breathing is great, but you have thrush. So rinsing their mouth, brushing their teeth is extremely important. And I think the most important thing to know about this is that it's not for use in an acute event. So if the patient is acutely short of breath, this is not the medication that's gonna help them. They need then albuterol or Duoneb or something like that, that's a short-acting bronchodilator, so it has a quicker onset of action. Spiriva is another medication that your patients come in on from home. It actually is, it comes with this little handy hailer, which they're actually changing the delivery method for the medication because there's been a few issues with the current setup and patients' understanding of how to use it. This is also a long-term, once-a-day medication. So just as with any other medication, the fewer times a day that the patient has to take it, the more compliant they're going to be. People are much more compliant with once-a-day or twice-a-day meds than they are with 4-time-a-day meds. So when we could move these respiratory medications to once or twice a day, the compliance for the patient really went up. In the current formulation of how this medication is delivered, there's a capsule that has to be punctured, and the patient has to inhale it. And you might think, why did you bold, patients do not swallow the capsules? You would be amazed at what patients do with the capsules. They swallow them. I couldn't swallow it, so I just opened it and put it in my coffee. Oh, I didn't know that that little lever was to puncture the capsule. I thought that just helped me hold on to it. So if you don't puncture the capsule, you can take all the deep breaths you want, you're not going to get any of the medication. And they recommend, the company does recommend that the patient use 2 inhalations just to make sure that they get all of the medication. Then they open it, especially at home use, and they just dump it out. You shouldn't really touch the inside of the device. But because of the whole concept of they have to puncture and they have to inhale, and they've had so many instances of patients not understanding how to do it, the company is really making a huge commitment to patient education and reformulating the device so that it's easier for patients to use and providing them with more information on it. And to wrap up, I'm just going to talk about 2 new initiatives that are going to be starting here in the next few months. We've just started them over the last few months at Danbury, and we'll be providing in-servicing to the respiratory staff here, and then we will be contacting Mary to set up more in-servicing for nursing as we move forward with this, just so that you understand what's going on and what our goals are. We're really looking to decrease COPD readmission. So COPD readmission is on the hit list, where if the patients are readmitted within 30 days, we're penalized for it. So we had to look at what could we do to impact COPD readmission. It's really an across-the-spectrum project. As I said, we will provide more details in a separate in-service, but we are doing things from the inpatient perspective, and then things are being done from an outpatient perspective as well, from the pulmonary office that's associated with Western Connecticut Medical Group. So the first thing we did was to say, how can the respiratory therapist impact this? At Danbury, the respiratory therapists do not administer inhalers. We don't do Advair, we don't do the Spiriva, the nurses do that. So we thought, how do we know these patients are doing their medications correctly? How do we know that they understand what the medication is supposed to do? Are there any socioeconomic barriers to compliance with their medication? Can they afford it? Do they know that a lot of drug companies have coupons and will work with patients that have financial difficulty? Because, sometimes people are choosing between groceries and their inhaler, and they're going to go with groceries. So does the company provide some kind of financial assistance? Is there a different, maybe less expensive medication that they could be on? And we actually started assessing the patient's flow rate, inspiratory flow rate, to make sure that they had enough inspiratory flow to actually use the device that they were prescribed. So every inhaled medication requires a different flow rate to be able to get optimal deposition into the lungs. So we actually purchased devices that will be in-servicing the respiratory staff here on as well. It's called an in-check flow device. And you look at the little card and it has all the current, different kinds of inhalers, and it'll say, okay, for a dry powdered inhaler, you need to generate, for example, 30 liters a minute of inspiratory flow. So we set the dial, patient inhales, they either inhale too slow or they inhale too fast. So then it gives us a starting point to say, okay, can you take a deeper breath for me? Maybe they can't generate enough flow to use the inhaler. Or they have plenty of flow, but they're doing it too quickly to get optimal drug deposition. So that gives us a starting point to work with them. And I think from that flow device perspective, it was interesting, because there's a lot of us in the respiratory field who use respiratory medications. And when we got the device, we're like, oh yeah, I use a spacer with my inhaler, I have great technique. Not so much. My flow for my device was way too high. Even though I wasn't setting off the little whistle in the spacer, I really had to retrain myself to have the appropriate kind of breath for the device that I was using. So we found that that was a big learning curve for patients. So we're spending time with them on that, and we have seen a good result. Our readmission rate has gone down. So that was kind of the easiest thing for us to target first, and that'll be the first thing that the therapists start to do here. The therapists here actually kind of have a leg up on the therapists at Danbury, because they're already familiar with the patients using their inhalers, and we were not. So they'll probably get into it a little bit quicker than we did. And we just started an oxygen ambulation assessment. And this is really to determine the appropriate amount of oxygen for a patient to go home on. Because we guessed at the beginning that maybe one of the reasons that patients were coming back in is that we sent them home on 2 liters a minute oxygen. And that was great when they were sitting in the chair. But when they got up to use the bathroom or they got up to make dinner, their saturations were dropping, they would become short of breath, they would call 911, they would come back. So we really are moving forward with that as the second phase of our initiative. So we actually take the patient off their oxygen, measure their saturation at rest without any oxygen on. And then we get them up and walk them, and we say, okay, as you start walking, your saturation is 87, let me put you on some oxygen. Let me turn it up, let me turn it up, let me turn it up to meet the goal. So then we may have an at-rest setting and a with activity setting for oxygen when the patient goes home. So we're hoping that we'll see some benefit from that as well. And I know you guys already get patients up and walk them, and Danbury Physical Therapy is doing a lot of them. But I think the important thing that may be a change in practice is that when they start to desaturate, we don't stop them from walking. We keep walking them and turn the oxygen up so that we can see what the best setting is for them. As I said, we just started this. We only ambulate patients who are not a fall risk, so that's a very small number of patients who are actually in the hospital. And that's a learning curve for us as well. That's where we had to start for our comfort, but we'll be moving, okay, everybody's using the Morse scale and you get 20 points if you have an IV. Does that really mean that we can't walk them? So that'll be things that we'll be looking at in the future, and as we move, as we move forward with that, we'll provide more. We always provide updates and education. And as I said, the therapists here will be starting first with the home medication assessment, And when they're comfortable with that, then we'll be moving into the oxygen inhalation. And before we do that, we will definitely provide more information, whether it's another in-service, if you'd like a more in-depth in-service, or just, communications like this is the dial, you might see us using this device. We're gonna, for the ambulation, it'll definitely probably be more of a group effort, because we're gonna need your help to be able to, take the patients off, what's the best way to monitor them in your setting, things like that. So that'll definitely be something that we'll work on together. But those are two new things that the therapist will be doing over the next few months. Any questions? Okay, thank you for coming.
Thank you.
As I said, the therapists here are really a great resource. Ask them anything, and Ashok is here during the day, and you can email me if you need, if you want further in-servicing or anything like that. But I guess I'd say just take advantage of the therapists here, because they really are a wealth of knowledge, and they really do a great job.